This next section, antihypertensive medications, will deal with the many different types of medications involved in lowering patients' blood pressure. In this section, we'll discuss antihypertensive medications. There are many different types of medications that treat high blood pressure. Some of these medications are very widely used, including ACE inhibitors and beta blockers. Other medications, such as hydralazine, have restricted uses. Blood pressure medications can target different factors that are causing the hypertension. Some of those factors include increased sympathetic tone, increased renin, water retention, and blood vessel tone. The classification for hypertension in adults is as follows. The optimal blood pressure for adults currently is less than 120 systolic over 80 systolic. Normal blood pressure is also considered to be anything less than 129 over 85. High normal or pre-hypertension is 130 to 139 over 85 to 89. And hypertension is considered to be anything systolic over 140 over 90. Severe hypertension can occur when a patient has a systolic blood pressure greater than 180 millimeters of mercury. The first classification of antihypertensive medications that we'll talk about are the medications that act on the central nervous system, and those include alpha-methyl-dopa, clonidine, and reserpine. Alpha-methyl-dopa, or Aldomet, is a prodrug that is converted in the body to alpha-methyl-norepinephrine. And this medication is selective for alpha-2 adrenoreceptors, which again are inhibitory receptors. This medication is very safe in pregnancy. It is the drug of choice for mild to moderate hypertension in pregnancy. The classic adverse effect, however, with Aldomet is Coombs-positive hemolytic anemia. As you know from your immunology lectures, Coombs tests for autoantibodies coating red blood cells. Patients that are taking alpha-methyl-dopa are more likely to develop Coombs-positive hemolytic anemia than other patients. Clonidine is another medication that's commonly used to treat hypertension that works on the central nervous system. Clonidine is an agonist at the alpha-2 receptor in the presynaptic neuron. When clonidine binds to the alpha-2 receptor, it blocks the release of norepinephrine from that sympathetic neuron. The effect is to lower blood pressure. Again, this is not a first-line medication. It's used in certain patients with uncontrolled blood pressure on other medications. It must be given 3 times a day, which is not easy to do sometimes for patients. Clonidine is associated with severe rebound syndrome. If it's abruptly stopped, it needs to be weaned off slowly. Reserpine is another antihypertensive medication that works in the central nervous system. The way that reserpine works is that it destroys storage granules of norepinephrine in the peripheral and central nervous system. Reserpine, because of its effects on norepinephrine and serotonin, can also cause major depression-like syndrome. However, it's safe and effective when used in small doses. Let's talk about some other medications that work on the peripheral sympathetic nervous system. These include guanethidine, prazosin, and beta blockers. Guanethidine is a quote-unquote false neurotransmitter that gets concentrated into vesicles and displaces norepinephrine. Even though it's packaged into vesicles and it's released by neurons, it does not bind to either the alpha or the beta receptor. It's not used anymore because of side effects. It can cause orthostatic hypotension and retrograde ejaculation. The next group of medications that we'll talk about is prazosin, doxazosin, and terazosin. These are alpha-1 adrenergic receptor antagonists. Remember that the alpha-1 receptor is responsible for increasing systemic vascular resistance, which increases blood pressure. These medications will reduce arterial resistance. These medications can cause syncope and orthostatic hypotension because they're very strong at lowering blood pressure. They're also able to work by decreasing LDL and increasing HDL. And remember that these medications are also commonly given to patients with BPH to prevent urinary retention. This is because they can relax the urinary sphincter. Beta blockers are another type of antihypertensive medication. These medications are very commonly used. These are medications that work by blocking the beta-1 receptor. This causes decreased heart rate and inotropy, which decreases cardiac output. decreased cardiac output will lower blood pressure. Patients that are taking beta blockers and have abrupt withdrawal may result in rebound hypertension in these patients, as well as tachycardia. Different beta blockers have different side effects and indications. It's also very important when switching from one beta blocker to another, it's important to wait for 2 to 3 half-lives, because different beta blockers can work on different types of tissue, and therefore one beta blocker should be completely out of the system before another beta blocker is started. If this is not done, patients may experience AV nodal or SA nodal blockade and may experience bradycardia. The different classifications of beta blockers occur based on their ability to bind and inactivate certain receptors. The first class that we'll talk about are the non-selective beta blockers. These are older medications. Propranolol and nadolol are oral medications, whereas timolol is the eye drop. These are medications that inactivate beta-1 and beta-2 receptors. The next classification of medications are the ones that can bind and block beta-1 and alpha-1. These are labetalol and carvedilol. Both of these are taken orally. Labetalol and carvedilol are also very good for cocaine intoxication. Some beta partial agonists include pindolol and acebutolol. These are not commonly used for high blood pressure. Specific beta blockers that block the beta-1 receptor only have the safest side effect profile. These include esmolol, metoprolol, and atenolol. And as we talked about already, esmolol has a very short half-life. Therefore, when given as an IV drip, it's able to be titrated on and off very quickly. Metoprolol and atenolol can be given orally. As we said before, non-selective beta blockers block both beta-1 and beta-2 receptors, and they include these medications, propranolol, nadolol, and timolol. Again, propranolol and nadolol are not generally used for hypertension anymore, though propranolol is effective for treating anxiety and panic disorders. These medications are used, however, to lower portal hypertension, especially in patients that have cirrhosis. Timolol is an eye drop for glaucoma patients. These medications may have significant pulmonary side effects because they also block the beta-2 receptor, which can cause bronchospasm. These medications are also notorious for causing AV or SA nodal blockade and bradycardia. The next classification are medications that block both beta-1 and alpha-1 receptors. These also may be partial agonists at beta-2 receptors. They include carvedilol and labetalol. Carvedilol is commonly given not just for blood pressure, but also for congestive heart failure. It's shown that the afterload reduction properties of carvedilol can improve mortality in these patients. Labetalol is commonly used for acute blood pressure control as well as cocaine overdose. The fact that they block the alpha-1 receptors mean that in patients that have cocaine in their system and have a high blood pressure because of it, the beta effects from these medications will decrease the heart rate, whereas the alpha-1 effects will decrease the blood pressure directly by decreasing SVR, systemic vascular resistance. Remember, cocaine raises blood pressure by causing vasoconstriction and tachycardia. These medications treat both of those. Selective beta blockers, or specific beta blockers, will block only the beta-1 receptors and not the beta-2 receptors. Sometimes these medications have minimal activity at beta-2 receptors. They include metoprolol, atenolol, and esmolol. Metoprolol is the most commonly prescribed beta blocker for hypertension in hospitals today. Atenolol is an older medication, but it is still commonly used. Esmolol is a very short half-life, and therefore in patients that have hypertensive emergency or hypertensive crisis, esmolol can be started for them and it can be titrated very quickly. These medications have very few pulmonary side effects because they do not bind to the beta-2 receptor. They can, however, cause bradycardia. The ideal resting heart rate in patients that are taking these medications should be between 60 and 80. Another classification of blood pressure medications includes the direct vasodilators, and these are hydralazine and nitroprusside. Hydralazine works in short-term treatment of moderate to severe hypertension. It can be given orally and intravenously, and it's very safe in pregnancy. It works by dilating peripheral arteries. The adverse effects of hydralazine include headache, flushing, and sweating. And this has to do with decreased blood pressure and dilation of blood vessels. Hydralazine is also classically associated with drug-induced lupus. It's more common in slow acetylators. Nitroprusside is another medication that's commonly given for hypertensive emergencies. This medication is metabolized into nitric oxide, and as you know, nitric oxide causes an increase in cyclic GMP in vascular smooth muscle, which leads to relaxation. The adverse effects of nitroprusside include vasodilation that can cause hypotension. Nitroprusside is also converted in small amounts in the body to cyanide and thiocyanate ions, which are obviously poisonous. During extended infusions, cyanide ions can actually be formed. Patients that are taking nitroprusside and develop cyanide toxicity can be given sodium thiosulfate to detoxify the cyanide in their system. The next category of medications that we'll talk about are the calcium channel blockers or antagonists. These medications include nifedipine, amlodipine, diltiazem, and verapamil. Verapamil is more selective for the calcium channels in the heart. This medication works to slow down AV nodal conduction. Nifedipine, diltiazem, and amlodipine are more selective for peripheral vessels, but they do also work to a small degree in the heart. These medications are able to vasodilate arterioles and coronary vessels and decrease cardiac contractility as well as slowing the AV nodal pathway. These medications are very good at improving hypertension that's related to low renin. What this means is that the hypertension is not related to decreased renal perfusion. Decreased renal perfusion, as you know, increases renin. And that renin that's released from the kidney works to activate the renin-angiotensin-aldosterone system. Calcium channel blockers are also commonly used in angina pectoris. And the reason for this is that they decrease overall cardiac work, which decreases oxygen demand, which improves pain. Calcium channel blockers, again, should not be used in a patient that has Wolff-Parkinson-White syndrome, in that these medications may encourage the use of the heart to use the aberrant pathway instead of the AV nodal block, instead of the AV node to transfer the signal from the atrium to the ventricle. These medications may precipitate AV nodal block and hypotension as well. ACE inhibitors are widely used antihypertensive agents. In general, these medications have a pril suffix, and they include enalapril, captopril, lisinopril, wayinopril, and ramipril. These medications have been shown by multiple clinical trials to have long-term benefits in patients that have post-heart attack ventricular dysfunction, diabetic nephropathy, as well as just heart failure, as well as patients that have hypertension. The way ACE inhibitors work is they block the conversion of angiotensin 1 to angiotensin 2. Remember, angiotensin 1 is a breakdown product of angiotensinogen, and angiotensinogen is converted to angiotensin 1 by renin. Because they work to decrease the concentration of angiotensin 2, they also decrease the formation of aldosterone, because angiotensin 2 stimulates the release of aldosterone. Angiotensin 2 also is a direct vasoconstrictor, and therefore these medications will cause decreased vasoconstrictive effects. ACE inhibitors, as a side note, also inhibit the metabolism of bradykinin, which increases the concentration of bradykinin. Bradykinin is known to cause a persistent dry cough and can also precipitate angioedema. The mechanism for this is not entirely clear. However, in these patients, the most important thing is to maintain airway breathing and circulation. Sometimes these patients need to be intubated in order to keep them breathing. The medication should be stopped right away if you see this. A newer class of medication includes the ARBs, or angiotensin II receptor blockers. These medications include candesartan, irbesartan, losartan, and valsartan. These medications so far have shown to be very effective and safe. It's unclear, however, if they will show all of the long-term mortality benefits that ACE inhibitors show. As you can tell, these medications are very similar to ACE inhibitors in that they work on the same renin-angiotensin-aldosterone pathways. The effectiveness has been similar, but they don't affect bradykinin metabolism. Therefore, they do not cause the cough that is seen in ACE inhibitors. And again, these are very well tolerated by patients for the most part. ACEs and ARBs can have some adverse effects, as you can guess. They can cause hypotension, hypovolemia. They can also cause hyperkalemia in certain patients. They can also cause taste changes, especially captopril. ACEs and ARBs should not be used in certain patients, especially those that have bilateral renal artery stenosis or renal artery stenosis of a single functioning kidney, in case they've had one kidney removed. The reason is that ACE inhibitors and angiotensin receptor antagonists will block angiotensin II's effects. And angiotensin II has been known to constrict the efferent arteriole. And efferent arteriolar constriction can actually maintain adequate glomerular filtration when the renal perfusion pressure is low. So therefore, patients that are taking ACEs and ARBs, it's important to make sure that they don't have renal artery stenosis. ACEs and ARBs are also contraindicated in pregnancy because they can decrease fetal urine output. This can lead to oligohydramnios and birth defects because of mechanical injury inside the uterus. This concludes our section on blood pressure lowering medications. Our next section will go over heart failure medications as well as medications given for chest pain.